Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we bring you the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and today we're talking about one of the more high-stakes neurologic emergencies that we're going to see in practice, and that's traumatic brain injury. So whether it's been caused by a fall, a hit by car, or really any other type of head trauma, these injuries involve complex pathophysiology, and their management is really multifaceted. So joining me today to walk us through the key considerations is Dr. Theresa Pancotto. She's a board-certified veterinary neurologist and a neurosurgeon, at Specialists in Companion Animal Neurology in Naples, Florida. She's also the author of a recent quiz-based article in Clinician's Brief, and that article really explored which drugs and interventions are indicated and which we should use with caution when managing traumatic brain injury patients. So if you're like me and you've ever wondered whether you really need to reach for Manadol or should you give a dose of dexamethasone, this episode is going to be for you. So thank you so much for joining us today, Doc. I am so excited to have this conversation.
Me too. I'm very happy to be here.
Great. Before we jump in, would you mind just giving a quick introduction and telling our audience a little bit about yourself?
Yeah, so I finished my residency in 2011 at Virginia Tech. I stayed on as a faculty member there until 2020. I then went to California, worked in San Diego for a little bit, went to Auburn University, worked there for a little bit, and then found myself looking for something a little bit different and wound up in private practice down in Naples, Florida. Outside of veterinary medicine, I an endurance athlete. I'm not very good at it, but I enjoy it. So I've done an Ironman triathlon. I don't know, probably a dozen, maybe 16 marathons, doing the Chicago Marathon next week, and other endurance races as well. So.
Oh, that's awesome. Good luck next week. We'll be thinking
Thank
of you. Yeah. Well, let's jump right in because I do have lots and lots of questions for you today. So first off, when I was kind of preparing for this episode, I really kind of dove into this idea of primary versus secondary traumatic brain injury. So can you kind of talk about the differences and why really preventing that secondary injury is kind of our goal when we're, managing these cases in the clinic?
Yes. So when we look at the two types of injury, primary injury, as you said, that's the mechanical and physical damage that occurs to the brain tissue. So whether that's the laceration of the tissue, a hematoma that forms, it's the structural change that occurs to the neural tissue itself. And then all the downstream side effects from that with respect to ischemic injury, changes in cytokines, changes in neurotransmitters are all of these secondary changers. And those are the things that, if left unmitigated, can lead to severe cerebral edema, brain swelling, and eventually brain herniation and death if those are not treated. We obviously have a much more limited capacity to control the primary injury because that's the event that happened in the first place. I can't reverse the fact that the dog got hit by a car or bit in the head, but I can remove any depressed skull fragments, and I can try to medically manage all those secondary changes as well.
That makes total sense. Beyond mentation changes, which, I think are a big thing that we think of with traumatic brain injury, what other neurologic, like postures or cranial nerve signs might alert clinicians that we really need to jump on this right away?
Yeah, so with respect to intracranial injury in particular and abnormal postures, certainly looking for decerebrate posture. You're going to have an abnormal mentation. The head and neck are going to be extended, and the thoracic limbs and pelvic limbs all held in rigid extension. And so that's going to be not only an indicator of severe injury, but it's also what we call a localizing posture, and tells you that there has to be changes to the cerebrum or forebrain to create that posture. So if you were to experimentally take a dog and remove its cerebrum and then wake it up, that's what it would look like. And that's why it's called a decerebrate posture. Decerebellate posture is similar. So you're going to have the extension of the thoracic limbs, head and neck, but you may actually see alterations between extension and inflection of the pelvic limbs. And you can also have kind of a twist in the body or pleurothotnus where they're a little bit more crooked. Now, depending on the type of injury that occurred, you may or may not have significant mentation changes. So if it's purely in the cerebellum, you're probably less likely to have mentation changes. If it's a more diffuse injury and you've got some compression of the brainstem, absolutely you'll see mentation changes to go along with that. So those are the two big ones. We also look for head tilts and head turns, which in a can occur with less severe injury. So head turns, we're going to see more with forebrain diseases. They're going to turn towards the side of the lesion, and head tilts with ear injuries, brainstem injuries, and cerebellar injuries. And the direction of the tilt really depends on where the injury is, if it's going to be towards or away from the lesion. So those can be helpful in localizing your problem, not just an indicator of severity.
Yeah.
Sorry. So, just to further expand on some of your question, looking at other specific cranial nerves, one of the ones that's most helpful to me is actually looking at the oculocephalic or doll's eye reflex. So when you're able to move the head and neck and watch the eyes move, that reflex will diminish as intracranial pressure goes up. So that's a key indicator for me about how serious the head injury is, because if that reflex is decreased, that's a huge red flag where I need to be intervening absolutely sooner rather than later. If it's intact, then you're obviously in a less critical situation. Similarly, PLRs are also going to be a key factor in evaluating intracranial pressure. So they can start by being dilated and non-responsive. They can turn myotic and non-responsive, and they can be anisocoric. So looking at PLR in response to light is also important.
Thank you. That was a nice review of a lot of that localization and exactly, what I want to know. What are those red flags that I really need to be concentrating on? They also, you talk a little bit in the article, and I've had a couple other guests on when we've talked about other things where we talk about this Cushing's reflex, and we know that's really described as kind of a late and grave sign when we have increased intracranial pressure. Can you walk us through the physiology behind that Cushing triad?
Yeah. So the Cushing's reflex occurs when the brain is no longer to compensate for changes in intracranial pressure. So you will see intracranial pressure increase to a point at which the brain can compensate by reducing vessel diameter, changing the flow of CSF. Brain's fairly limited with how it can move and respond to adding things into the calvarium, but it can reduce the size of blood vessels and change the flow of CSF, so decreasing the volume that is within the calvarium. But that's going to reach capacity fairly quickly. And so once swelling goes beyond that, that's when you risk brain herniation. So what happens as the brain continues to swell and swell and swell, it's putting more and more pressure on the blood vessels that deliver oxygen and glucose to the brain. So as the brain becomes depleted of oxygen and glucose, it's going to send out a massive sympathetic discharge to the body that says, hey, I need to have oxygen, I need to have glucose, we're about to die here. And so as a response to that, we're going to see the heart rate go up to try and deliver oxygen and glucose to the brain because it doesn't have it. But then your carotid body and aortic body receptors are going to be freaking out because they're like, oh my God, my heart rate or my blood pressure is so high. What am I going to do? And that's when you get a reflex bradycardia. So blood pressure goes up in response to the sympathetic output in demand for oxygen and glucose. That's perceived by the carotid and aortic body receptors, and you get a reflex bradycardia. So the numbers that I look for, if you look at the standards for hypertension, 160 to 180 is a gray zone. So that's where it's like, I don't know if this is technically going to be a Cushing's reflex or not. Certainly anything over 180 is going to be our first red flag. And then the reflex heart rate that starts to alarm me is around the 60 beats per minute. And then anything less, obviously being bradycardic. Those two findings together would indicate a Cushing's reflex. And it's important to have both of those things because obviously any patient that has, significant other body trauma, if they're hit by a car, could be in hypovolemic shock. So they're going to have a really high heart rate, or if they're in decompensated shock and they have a really low heart rate, but their blood pressure is also really low, that dog's not having a Cushing's reflex. It needs volume replacement. So it's important to check both the blood pressure and the heart rate in conjunction with your neurologic exam.
That makes sense. I want to jump right into, all of these interventions. You were just talking about how swelling is, one of the, the things we're trying to prevent, but really glucocorticoids like dexamethasone and methylprednisolone are not considered indicated in most cases. Are there any exceptions where steroids might still be appropriate?
For acute traumatic brain injury, I'd say no. And that data comes from a study that was done in people called the CRASH study. And if I try to tell you what all the letters stand for, I will definitely mess it up. But basically, they randomized individuals who had traumatic brain injury of any cause that were presented to the ER to getting corticosteroids or not getting corticosteroids. And they ended up having to end the study early because those with corticosteroids were progressing and actually dying from their condition at a much more significant rate than the ones that didn't receive anything. And so we extrapolate that to veterinary medicine, even though there aren't the same studies that exist in our patient population. So for acute TBI, no. Now, if you're dealing with things like bite wounds that maybe don't go addressed right away and later develop into an abscess, and so then you're looking at not only you're taking skull fragments out, but we're having to drain the abscess and cover that, then steroids might actually be helpful in mitigating the edema associated with the infection in the brain.
Okay. Do you think NSAIDs are any safer than glucocorticoids if we have a patient that really we want to use an anti-inflammatory in?
I don't think there's data out there that says they're contraindicated. I think it ultimately comes down to why do you need the NSAID? It's probably not going to be as helpful for treating the things that we're worried about in the brain. If we're worried about edema, mannitol, hypertonic saline are going to be the way to go. Versus if we're worried that they have pain in a limb and we're trying to treat limb pain, I can see a utility for an NSAID, but it might be better off in the trauma setting to be using things like opioids, injectable pain medication that we have a little bit more ability to control and titrate, especially we're using things like a fentanyl CRI.
Yeah, that was exactly kind of the situation that I was thinking about. If we had a hit by car or dog bites other places, do we want that not only for the anti-inflammatory effects, but also for the pain management? And, you do say that acute pain management is really critical in these patients.
Mm-hmm.
Can you explain why inadequate analgesia might contribute to worsening intracranial pressure or delayed recovery?
Yeah, so pain obviously is going to stress patients out. And the more stressed they are, the higher the heart rate is, the more uncomfortable they are. It's just going to accelerate the changes in intracranial pressure, making things worse. And so decompensating where they might already be on the brink of maintaining a normal intracranial pressure, if they get really painful and agitated, that could set them over the edge.
Okay. And then you did briefly mention fentanyl CRIs. You talk about it in the quiz too. It's one of the medications that you present. I personally don't have a lot of access to fentanyl. So for people like me, for practitioners like me, when fentanyl isn't available, what alternative opioids do you like in these patients?
Yeah. So the nice thing about CRIs, whether it's fentanyl or a different opioid, is you have the ability to adjust it, essentially by the minute or discontinue it right away. And if you're using a pure opioid, you can also reverse it with naloxone. So those are the reasons that I do like opioid CRIs, whether it's fentanyl or something else. When we're talking about traumatic brain injury, if we exclude pain from other concurrent injuries, I actually like buprenorphine because there aren't really significant pain receptors in the brain. And there's not, depending on which animal you're working with, there's not a lot of muscle on top of the head either. And so the amount of pain that they're actually in and the quality of pain that they're experiencing is going to be very different than like a limb fracture, to where treating the underlying causes, controlling the edema, controlling any seizures is going to be what makes them more comfortable than necessarily an opioid. But I do like buprenorphine because as only a partial agonist, I like it for that reason. So it's not as strong. You don't see a lot of the vomiting and nausea that you're going to see with some of the pure opioids. So if I'm doing brain surgery and I'm needing a postoperative opioid and I don't have fentanyl CRI, I actually pick buprenorphine, would be my next choice.
Yeah, no, that's great. Certainly, I didn't even think of things like, hydromorphone and stuff can cause so much nausea. And if we have traumatic brain injury, we don't want to be vomiting on top of that.
Yeah. And I mean, we used to use a lot of remifentanil CRIs at Virginia Tech. I don't have access to that now, so it's not something that I get to use very much, but that's another one that's available that we like for total IV anesthesia and brain cases as well.
Perfect. We're going to take a quick break and then we'll jump back, and we are going to talk about a lot of those hyperosmotic agents. Are you on track to hit your CE goals? Clinician's Brief has more than 60 hours of practical, RACE-approved CE, perfect for catching you up and keeping you up on requirements. Whether you prefer to read, watch, or listen, Clinician's Brief CE is on demand and always affordable. Start earning CE today at cliniciansbrief.com/CE. Okay, so as you were saying before the break, mannitol and hypertonic saline are really our mainstays of reducing intracranial pressure. They are a little bit different in their mechanisms of action and their durations. So can you speak to that?
Yeah, and I'd say I'll start with saying if you talk to a criticalist and you talk to a neurologist, they're probably going to be reaching for different things. And there are lots of papers out there that support both. There's papers that show benefits of hypertonic saline compared to mannitol in some studies, and then vice versa, showing that mannitol is beneficial, more beneficial than hypertonic saline in other studies. Both of them work well, and whatever you have available to you is worth using in the face of TBI. So mannitol has quite a few mechanisms of actions. It is a hyperosmotic agent, but it also has rheologic properties and will improve the blood flow beyond just the fact that it draws water into the bloodstream. You do have to make sure that that is warmed and or delivered through a filter, because it can crystallize, and that can be problematic when administering it to patients as well. The other thing to be aware of with mannitol is you can give it too quickly and actually cause rebound increases in intracranial pressure. So you want to make sure that it's delivered over usually 20 to 30 minutes. That somewhat depends on dose. If I'm using a full gram, I'm definitely erring on the 20 to 30 minute side, versus if it's just a half gram per kilogram, 15 to 20 minutes is probably okay.
Okay. And then I know you said kind of what you have on your shelf is what you should be reaching for in an emergency situation. But if you had access to both, or are there any patient factors that might steer you to one versus the other?
Yeah, that's a good question. So if I'm more worried about volume loss, that's where hypertonic saline can help you out a little bit more than mannitol. Mannitol is not going to do quite as much for restoring volume as the hypertonic saline. You can usually also give more volume with hypertonic saline. And I do like to combine those with things like hetastarch. So if I'm worried about volume loss in a patient, I want to limit my crystalloids. I don't want them immediately flooding into the brain and worsening edema. So combining that with hetastarch or hypertonic saline and hetastarch can be very helpful to be able to restore volume, which is needed for the patient. You don't want to not have appropriate patient volume in favor of saving the brain. You have to save both of those things. But I do like that combination for those cases.
Yeah, so really it's kind of that balancing act between supporting their blood pressure, but still avoiding overhydration. Like you said, that could worsen the edema. Does furosemide play a role at all in that? Can we use diuretics to manage that intracranial pressure?
So if your patient is not dehydrated, then you can certainly use diuretics. But if you're in a facing volume loss, or they're dehydrated they've been out, on the streets for a long time, haven't had access to water, and then they get hit by a car. So stray animals, that sort of situation, and you're worried about dehydration, I would try to avoid the diuretics. You want to restore your volume first. And then as a last ditch effort, or maybe even 24, 48 hours down the road, if you're still trying to mitigate those secondary effects, furosemide could play a role down the road.
Yeah, I guess that kind of leads a little bit into my next question, which was like, when we have these multiple agents and sometimes they seem to work a little bit, against each other, how do you typically sequence them, especially with, like you said, the crystalloids and the hyperosmotic agents, and then I guess potentially adding in the diuretics, quite a bit later?
Yeah, there's probably a very complex way to answer that eloquently that I'm going to miss. But you kind of, assuming these cases are presenting on an emergency basis, you're taking one problem at a time. So depending on what you recognize first, if the first thing that you recognize is the Cushing's reflex and you're pulling up mannitol, great. If you then identify that the patient has, a PCV of 20 and is probably volume depleted, then adding in your crystalloids and head of starch are appropriate. So I think depending on how you receive the information will really dictate the order in which you treat. And because, especially with things like mannitol and hypertonic saline, they're delivered over a period of time. So you're continuing to reassess the patient in that period of time. So if we're looking for those synergistic effects of furosemide and whether or not it's contraindicated, by the time we get the mannitol in there, we will know if they need it or if they actually need volume resuscitation and be able to decide whether or not we should use furosemide as a chaser versus just sticking to the hyperosmotic agents.
Perfect. Let's talk a little bit about seizures. How common are seizures in patients that present with traumatic brain injury?
They're fairly infrequent. There's a couple studies out there, several in cats and some in dogs, and they look at the onset of post-traumatic epilepsy. And I don't have the numbers in front of me, but it's less than 6% in both species. I think that's as high as it goes, but 1 to 3 is probably more typical. And when we look at post-traumatic epilepsy, it doesn't necessarily mean they have a seizure at the time of presentation. It can really be up to months or maximally 2 years after the traumatic instance to be considered post-traumatic epilepsy. And that still falls into that 1 to 3%.
Interesting. You said in the article that levetiracetam is really your first-line anticonvulsant. Why is that, and how does it compare to phenobarbital?
Yeah. So levetiracetam or levetiracetam, I don't know how you say it. I don't think anyone does.
I don't think anyone does.
I like it in the face of TBI because it's generally not sedating. So even though if we look at its efficacy in the population of idiopathic epileptics, it only works in about 30% of dogs. I like it in the face of TBI because I know that I'm not going to iatrogenically induce a coma in that patient where I'm then wondering, okay, did I cause the coma or is the disease worsening? And that's why they're in a coma. So the Keppra allows me a little bit more flexibility as far as controlling their mentation and not having any negative impacts on their mentation. It also has very wide safety margins. So we start dosing levetiracetam at 20 mg per kg 3 times a day. And you can go up to about 330 mg per kg before you really even get to anything close to toxic. And that's per dose, 330 mg per kg per dose. So essentially 1,000 milligrams per kilogram per day. So you have the ability to repeat that dose in a short period of time without causing, again, more negative side effects. So it has a wide safety margin, minimal side effects, and that's why I like it in the acute TBI setting. Phenobarbital is great as far as preventing and treating seizures. It does have neuroprotective properties, but it does cause sedation. So if I'm not comfortable with a patient's mentation, then I'm not going to pick phenobarbital. Now, if it's a relatively stable patient that comes in ambulatory but had been bit or hit by a car, or is at least moving their legs and relatively intact mentation, I might be more inclined to pick something like phenobarbital, but the mentation is going to be a big factor with why I choose levetiracetam first.
And you just said that this is actually pretty rare. So should anticonvulsants ever be used prophylactically, or do we just reserve these for if we are seeing seizure activity?
There's no data to show that prophylactic treatment with anticonvulsants truly helps. So it kind of ends up being a waste of the client's money. I tend not to do that. Now, if I am taking a pet to surgery, I will put them on perioperative anti-seizure medications because whenever you go mucking around in the brain, you want to try to prevent any worsening of seizure activity then, because seizures near the time of surgery are going to increase the risk of aspiration pneumonia, and that obviously can be a life-threatening complication. So I do use them around the time of surgery, but I won't use them in a TBI patient that doesn't need surgery and hasn't presented with seizures.
Okay, perfect. Another thing that happens with traumatic brain injury patients is they often present with hyperglycemia, high blood sugar. Is this something we should be treating with insulin?
We don't need to treat the hyperglycemia associated with either seizures or traumatic brain injury. We do know that the higher the blood sugar level is, the worse the injury is, and it can propagate secondary mediators of injury. However, when you start treating all the things that you find wrong on the dog's exam, so when you're treating increased intracranial pressure, when you're providing volume resuscitation, when you're getting any seizure activity under control, and you're controlling pain management, the hyperglycemia is going to resolve on its own. So we really don't need to do anything to bring it down. It's going to get better on its own.
Should get better just with our other treatments.
Correct.
Okay. And then I want to call back to that Cushing reflex that you talked about, where we've got our high blood pressure, but our heart rate is low. You said you start to get concerned when we have a bradycardia of, 60 or below. What if we're really low? What if we're 20 or something? Should we be giving these animals atropine? Is that ever indicated?
Only if their blood pressure is also low. So if you have a patient that's like in decompensated shock, they're not maintaining their blood pressure and their heart rate is really low, like their oxygen delivery is going to be low to their brain. So we need to try to restore normotensive. So we want their blood pressure into the normal range and we want their heart rate into the normal range. So we don't want to overcompensate, but we don't want to undercompensate either. But certainly if the blood pressure is not adequate to sustain normal function, and the heart rate is also low, that would be a reason to use atropine or glycopyrrolate.
Yeah, to get that heart rate up. Okay. Drug selection is just like one piece of the puzzle when we're managing these guys. What about other supportive therapies, oxygen supplementation, elevating their head, temperature regulation? How do these all contribute to patient outcomes?
Yep. So we know that cold is neuroprotective. So in people, especially if you've ever watched a football game with a traumatic injury, often you see them pack those people on ice and get them off the field. So we know that cold is neuroprotective. There's not a lot of great studies in dogs that have actually induced hypothermia near the time of TBI to be able to demonstrate that as well. So most neurologists, or at least myself, we don't actively warm patients unless they're below 93, 94 degrees. So if they're a little bit on the chilly side, but not a popsicle, I usually just leave them, wait till I get everything else under control and see what their body temperature does. Sorry about my light. So generally, most people are not actively cooling their patients, even though cold seems to be neuroprotective. Absolutely elevating the head and avoiding jugular venipuncture is helpful. So if you think about everything in the brain, vascularly wise, is going to drain via the two jugular veins. If you puncture one of those, or if one's lacerated in trauma and gets clotted, you've essentially reduced blood flow by 50% in the brain, which is only going to make intracranial pressure go up. So keeping the jugulars preserved and then elevating the head by about 45 degrees is also just going to promote gravitationally the continued flow of spinal fluid and blood out of the calvarium. So we try to elevate the head as well. And when you do elevation, you want to make sure that it's not just under the head itself, but really elevating from the shoulder up. Because if you just kink the head, you could actually put pressure on the jugular vein itself, and then you're reducing blood flow and not achieving what you want to achieve. I feel like I forgot one of the ones you mentioned.
Oxygen.
Yes.
A little bit about oxygen.
So until we, again, have kind of had an opportunity to assess all of the patient's body functions and see where they are with respect to total body volume, whether or not they're anemic, how much blood have they lost, if any, good oxygen supplementation while you're making those assessments isn't going to hurt. So providing flow by oxygen, definitely worthwhile until you've really made an accurate assessment with what the patient's pulmonary injury is, what their volume status is, what their blood volume status is, to decide whether or not they need it or not. Because having some extra circulating oxygen is not going to be harmful to the places that it can get.
And kind of the final, kind of wrap up I want is me as a general practitioner, oftentimes I will see these guys on emergency, just like you said, hit by car, gets rushed in, or, a fight at the dog park. How do I know when they're stable to transfer? Because I'm not going to be doing brain surgery. I'm going to leave that to you. And also, what should we be communicating to clients about the recovery timeline for these cases?
Yeah. So with regards to when you should refer, if you don't have the ability to do 24/7 monitoring, or you don't have any of those medications that we talked about, and so you're not able to fully resuscitate the patient, then getting them to an ER or another practice that does, absolutely. If you are worried that there's something more structural damage to the head, so if you see a divot in the head where you can tell that there's skull trauma, or if you end up taking radiographs and you can see that there's a skull fracture, that would be a reason to send to a neurologist because we're worried that that patient might need surgery. So any obvious skull fracture would be a reason to send. If you are doing everything right, you have all these drugs in front of you, but the patient isn't responding and they're continuing to decline or at the very least not improving, then you would want to send to a neurologist likely for advanced imaging to see what's going on in the head that we need to be able to do something different, whether it's a decompressive craniotomy, or something else. Referral for imaging would be indicated if they're getting worse, no matter what you do. As far as recovery goes, it's really all over the board. With monitoring in the recovery period, I like to use the modified Glasgow Coma Scale score, which you can look up online. It's fairly easy. There's also an app for it as well. You can also call a neurologist and they'll usually talk you through it too. So it looks at motor function, cranial nerves, and reflexes. And so based on those three, at the low end, if a dog is basically failing everything, the lowest they can have is a 3 on the scale. And if they're doing everything really well, they would be as high as an 18. And even though we know that at presentation, lower scores are associated with worse long-term outcomes, the trends actually matter more than anything. So you could have a patient that comes in at a 3, but you give them a dose of mannitol and start them on IV fluids, and 2 hours later, they're a 7, and then 6 hours later, they're a 12. That dog is going to do much better than a dog that comes in at 12, you start monitoring and they turn into a 6, even though you were doing everything right. So trends matter, in my opinion, a little bit more than just the value that they're presenting with. So the Glasgow Coma Scale score is helpful for that as well. With respect to long-term recovery, if the injury is confined to the forebrain, so cerebrum, the sad truth of the matter is that part of the brain is not super important for dogs, so they can have pretty severe injury there and still have an excellent recovery and great quality of life. When you're talking about injury to the thalamus and brainstem, it's a little bit different. Those are much more important, and that's obviously a much harder area to reach from a traumatic standpoint as well. Mm-hmm. So if you've got disease that's affecting that part of the brain, those are ones that are a little bit more scary, where we do worry about long-term recovery. Same with the cerebellum. It's kind of a less essential part of the brain, but if it gets really swollen and it presses down on the brainstem, then you can certainly run into issues because that's where your respiratory centers are, and ultimately the influence over the cardiac functions live in the brainstem as well. So you start having issues in the brainstem, and that's where life-threatening becomes a real concern.
Yeah. Okay. Well, that was all of my clinical questions. That was a great discussion. I loved it. I learned actually several things. So before I let you go, there is one more little just game that we play at the end of our podcast, if you would like to. It's just a series of would you rather questions. There's no right or wrong answers. It's just for fun.
Yeah, let's do it.
All right. Would you rather perform a neuro exam on a lion or an alligator?
A lion. I've done a lion though, and I haven't done an alligator. So I don't know if I want to do an alligator.
You don't know if you want to do an alligator? No. How was the lion? Was it really cool?
The lion was fantastic. Yeah. Yeah. I've actually examined 2 lions and 1 serval.
Awesome. Yeah. Very cool. Big cats. All right. Would you rather star in a reality TV series about veterinary neurology or be the inspiration for a fictional neurologist character in a novel?
Be the inspiration for the fictional character.
You're not going to be on TV?
No.
Would you rather practice without injectable anticonvulsants or without injectable corticosteroids?
Oh, that's tough. Probably without the injectable corticosteroids. I think I would rather have the injectable anticonvulsants.
Okay. All right. Would you rather see nothing but surgical emergencies or nothing but medical emergencies for an entire month?
I'd rather see nothing but surgical emergencies for an entire month.
You want to go to surgery? Awesome.
Yeah.
All right. Last question.
Okay.
If you were localizing a lesion to the trigeminal nerve on the central head of Cerberus, the 3-headed dog, would you denote that in the medical record as cranial nerve 17 or as cranial nerve 5B?
5B.
5B? That makes more sense. Awesome. I'm glad that you were like right on that. You were like, I have an answer.
Yeah, that one I would have to. Yeah, that's easy.
Awesome. Well, that was all. That wasn't so bad, right?
No, not so bad.
Awesome. Thank you so much for taking the time to talk with us today. Thank you to our audience for listening. I hope you all learned as much as I do. And if you want to jump over to cliniciansbrief.com and take the quiz, you should all ace it now.
Thank you so much.
Thank you for listening to Clinicians Brief, the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.